Hi, I'm Dr. Steve DiPaula from Thomas University, and today I'd like to talk to you about suicide. What I want to do for a few seconds is give you an overview of my talk so that you have some structure for understanding what I'm talking about. I'd like to talk about suicide in the United States, give you some brief statistics. I'd like to talk about the issue of professional training. Do mental health practitioners need more professional training in the area of suicide? I would also like to talk about risk factors, warning signs, and protective factors when dealing with suicide. Lastly, I would briefly want to mention assessment models that are out there that will provide the clinician with structure when doing a suicide assessment. One of the things we know now is that every suicide is different. Every suicide is experienced by multiple members of that person's environment. We were all shocked this year when Robin Williams hung himself at 63. When someone commits suicide, we struggle with it, trying to find meaning and trying to make sense of the death. That finding meaning and making sense out of the circumstance is also done by the families who struggle with it for years. Every suicide is different. We also had another famous actor, Philip Seymour Hoffman, who committed suicide. Again, the general public, his fans, struggle with making sense out of why this great actor committed suicide. Why did this great actor, who appeared to have everything going for him, commit suicide? His family struggles with that to this day, trying to make sense out of why a beloved father and family member committed suicide. Every suicide has its own story. There's a story to tell. And one of the things that the grieving family members have to do is to retell their story of why the person committed suicide. And that is an ongoing struggle that they will deal with for years. I have on the slide an example of a young lady who was 13 years old who committed suicide by hanging herself. Her parents weren't aware of it. She came into her dad's bedroom that night, gave him a kiss, told him that she loved him, and went to bed. They were shocked when later that evening they went into her room to check on her and found that she had committed suicide by hanging herself. Every suicide is different. Every suicide has its own story. Here's an example of a suicidal note left. I lay in bed for hours in the dark at night, thinking about every possible thing I fucked up in my life. Every suicide is different. Every suicide has its own painful story. And the victims that are left behind will attempt to reconstruct their stories in creating meaning for that person's life and their lives. What I wanted to do is talk briefly about some statistics regarding suicide in the United States, and the Center for Disease Control in Atlanta collects lots of these statistics yearly. For example, in 2011, 39,518 people killed themselves. In 2012, 40,600 suicides reported. What that means is that suicide is the 10th leading cause of death in the United States. That means that someone in this country dies by suicide every 12.9 minutes. Now that doesn't include the over 400,000 people who are treated in emergency rooms for self-inflicted injuries. After cancer and heart disease, suicide accounts for more years of lost life than other causes. We've been alarmed about suicide for many, many years, and mental health organizations and scholars have been calling for more information, more models regarding suicide so that we can act appropriately. I think one of the best ways to look at our lack of focus and understanding of suicide is that if a commercial jet crashed every day in this country, killing 85 people, we would be alarmed, we would be outraged. We'd be calling for new information, the government would be involved. but we don't have the same level of focus or the same concern when we talk about suicide. And I think that's because we focus on the one person who commits suicide, neglecting all the people that are impacted by that person's death. Research indicates that at least 6 people are impacted psychologically and emotionally by someone who commits suicide. The big question in the mental health field is, do professionals need more training when dealing with suicide? And the answer from several research studies indicates that's yes, a strong yes. We don't get enough training in graduate school, and we don't get enough ongoing training when we're dealing with suicidal clients. We do know that the management and treatment of suicidal patients is one of the most stressful tasks that a clinician or mental health practitioner will experience. Survey research suggests that 28% of psychologists and 62% of psychiatrists will report having lost a patient in the past year. Dealing with a suicidal client is overwhelming, it's stressful, it causes us to question our clinical abilities. Related to this is the research that suggests that a large number of people who kill themselves have had recent contact with a mental health professional. It leads to this chronic crisis management, and it's ongoing, and we sometimes neglect the therapeutic goals that we had originally established. In 2004, the American Association of Suicidology created a competency-based curriculum that only takes 1 day to complete. There are multiple modules that were created in the areas of assessment and management that the person works through. It's a step in the right direction, but there's more work to do. What I want to do for a few minutes is talk about static risk factors. These are factors like gender that are unchanging. Major factor is that 90% of all completed suicides involve individuals who have diagnosable psychiatric disorders. 90% of these people are struggling with a mental health disorder. The important variable when we talk about psychiatric disorders is combining the total number of co-occurring psychiatric disorders. That's a powerful predictor. One disorder by itself isn't a strong predictor, but combining the psychiatric disorders is very important. We also know that males complete more suicides, however, females attempt more. The strongest risk factor for predicting suicide is a history of suicide attempts. The more serious the suicide attempt previously, the more important it is in assessment. Individuals who make a single suicide attempt are more likely to die by suicide when you compare them to the average person. Again, no single static risk factor provides an overwhelming diagnostic tool. They must be put together and they must be looked at individually in that client. Proximal warning signs. These are acts of rehearsal where the person is rehearsing suicide. These are thoughts of suicide, stressful life events in the person's life, and these are the cognitive, emotional states that the person is experiencing. These are all transient, these are all episodic. They are more likely to predict an immediate crisis that the clinician needs to deal with. A very important proximal warning sign will be stressful life events that the person is trying to cope with. In particular, we're talking about interpersonal loss and humiliation that increase the risk for suicide. Suicide rates spike immediately following discharge from a psychiatric hospitalization. Research suggests that day 1 after hospitalization, week 1 after they're discharged, and the first month after discharge are very important in dealing with potential suicide attempts. A variable that's assumed to be an important warning sign is suicidal ideation. However, research indicates that suicidal ideation predicts future suicidal ideation and not suicidal attempts. Predictive factors are very important when you're coming up with a treatment plan. And one very important predictive factor will be strength of religious convictions. Do you belong to a church that prevents suicide, or it is morally wrong to kill yourself? Individuals that belong to churches that are against suicide are less likely to kill themselves. Churches are also important because they provide spiritual practices, providing coping skills. Churches are also important because they provide social support that is needed. And we know that people who are socially isolated have trouble with suicidal ideation and are more likely to attempt suicide. Marriage is a very important factor. However, high conflict marriages and marriages where there is violence increase the risk of suicide. The presence of children is a very important protective factor for women. They're not going to kill themselves because they have to take care of those children. It's interesting that research also indicates that when women are providing the constant and stressful care for children, suicidal ideation increases. But again, suicidal attempts are not predictive. Close family ties, a supportive environment, are also an important protective factor that have to be taken into account in coming up with therapy models for suicidal patients. I briefly want to finish my talk talking about suicide assessment models. There are a variety of different models out there. Most of them are standardized, and the goal is to assess the immediate crisis and to engage in proper therapeutic skills. These assessment models also frame how therapy will take place with the client. I'm just going to briefly mention 4 models. They're out there and they're easily accessible. A recent model that was published in Psychotherapy in 2012 is called the Suicide Assessment 5-Step Evaluation and Triage. It's an actual manual. You walk through it. It specifically tells you what to do. The next one is the Collaborative Assessment and Management of Suicidality. This is, again, specific steps, specific risk assessment model. Chronological Assessment of Suicide is another very important one. And last, published in 1999, is the Suicide Risk Assessment Decision Tree. Again, these models are important because they allow you to assess the immediate crisis, but they also serve as a model for therapy with the client. Thank you very much for attending.